ma'ams. This is Dr. Priyadarshini, one of the mentors at StudyMEDIC, and today we are doing the RRR series for MRCOG Part 1 exam on the module Physiology. So starting with the quote, what you do today can improve all your tomorrows. And we know that you are preparing for your MRCOG exams, and this video will definitely help you crack some important topics in this module. So let's start with some question and answers. Going to the first question. A 30-year-old woman delivers a healthy baby vaginally. On day 10 postpartum, where is the fundus of the uterus expected to be palpated? So this question is targeting the physiological changes in pregnancy and postpartum. Let us look into the options. At the level of xiphoid, at the level of umbilicus, midway between the umbilicus and pubic symphysis, at the level of pubic symphysis, and is it no longer palpable? So there are various positions of the uterus that are given. We need to understand both in the antenatal period and in the postpartum period, these levels of uterus are considered important. And the answer for day 10 postpartum is it is going to be at the level of pubic symphysis. So by day 10, we expect the uterus to have involuted. The complete involution of the uterus completes by 6 weeks postpartum. At the level of xiphoid process, it is basically the term uterus we palpate there. Umbilicus, the uterus will be at the level of umbilicus in the immediate postpartum, that is by day 1. Midway, it is somewhere between day 4 to day 6, and it will become no longer palpable by almost 2 weeks to up to 6 weeks. This is a picture showing the positions of the uterus in both pregnancy and in the puerperal period. So in this module of physiology, you can expect some image-based questions, and a quick tip is to look at some familiar images and keep yourself updated for the exam. Going on with the next question. What is the approximate percentage increase in renal blood flow during pregnancy? This is one another question targeting the physiological changes of pregnancy. And for the physiological changes, we need to remember the renal system is one that is mostly targeted in exams. The remaining ones are your cardiovascular system and your respiratory system, and a bit of hematological changes also you need to understand. Now going back to the question, we have the options of 10%, 25%, 35, 50 and 75%. The right answer for this question is 50%. The renal blood flow increases by approximately 50% during pregnancy. Why is this so? It is because of the increased cardiac output and the renal vasodilatation that is seen in pregnancy. Usually in the first trimester, it starts as low as 10 to 25%. And by mid-trimester, we expect it to rise up to 35%. Usually 75% is too much of an elevation. So the right answer here is going to be 50% increase in renal blood flow. So what are the changes in the renal system? Quickly, the anatomy changes by 1 centimeter. There's an increase and there's a dilatation of the kidneys more on the right side compared to the left. There is more vasodilatation, increase in the renal blood flow and the GFR. There is an altered in the tubular reabsorption rates. We can see especially proteins, glucose, amino acids are being altered. There is electrolyte balances which keeps changing. We see that the total body sodium is going to increase. The potassium level is also increasing. This is all because of the renal changes in pregnancy, the physiological changes, and there's expansion of the plasma volume. Going on with the next question. By how much does the glomerular filtration rate increase in pregnancy? So we just saw about renal blood flow. Let's look about GFR. Is it by 20, 30, 40, 50 or 70%? Again, the answer is 50%. So renal blood flow and GFR increases by almost 50%. So what are some important points you need to remember? There's a 40 to 50% increase in your renal blood flow and your GFR, leading to creatinine clearance is potentiated in pregnancy. There's a reduced level of serum creatinine, urea and uric acid. This is by almost 25%. There's an increase in the fluid volumes, almost 50%. There's an increase in your extracellular volume. In the extracellular, if you see the intravascular is 50%, the remaining is the interstitial component. The sodium and potassium level needs to be maintained. Though there are so much of physiological changes, we cannot let the sodium and the potassium level, let it be whether it is going towards hypo or hyper. It is not accepted, and hence those levels will always be maintained. There is an increased chance of metabolic acidosis because it's a chronic loss of renal bicarbonate ions. Going on to next, yet another important question. What is the outer protective layer of the Graafian follicle? Is it the zona? Is it theca externa? Is it theca interna? Is it the granulosa cell or is it the corona radiata? This is one hot favorite question that we see in the exams, and understanding the structure of Graafian follicle is really considered important for this exam. The answer is theca externa. Now, the outer protective layer of the Graafian follicle is the theca externa, and this is mainly composed of some connective tissue, and it is giving the structural support to the Graafian follicle. Now, what about the other layers? Now, zona pellucida is nothing but it's a glycoprotein layer that is surrounding the oocyte, and it is not in the Graafian follicle. We know the oocyte is somewhere present within the Graafian follicle. Theca interna is a layer that is below the theca externa, and this is the layer that is going to produce androgens. Coming to granulosa cells are involved in estrogen production, and they are located around the antral cavity, and they are not present externally. Now, what is corona radiata? Corona radiata is a group of cells that is going to surround the oocyte, especially after ovulation. It plays a very vital role, and this is not present in the follicular layer. To give you a better understanding, this is the image of the mature Graafian follicle. You can see that in the middle you have the oocyte, which is protected by the zona pellucida and the corona radiata, and we have the antral follicular cavity or the antral cavity. And externally, if you see, we have the theca externa, and internal to that is the theca interna, and innermost to that is your granulosa cells. Coming to another important topic, it is about the lung volume changes in pregnancy. Again, the physiological changes of pregnancy are being tested here. The question is, which lung volume decreases in pregnancy? Is it the residual volume? It is the tidal volume, inspirated reserve volume, functional residual capacity, and vital capacity. This topic or this concept of understanding the lung volume is very important. It is a time-tested question. You can either have the spirometric graph or you can have direct questions like this. So right answer here is functional residual capacity. This decreases in pregnancy. And why is it so? One is because of the anatomical position. The displacement of the diaphragm is upward because of the enlarging uterus. And what do you mean by functional residual capacity? It is nothing but the volume of air that remains in the lungs after a normal exhalation. The residual volume, yes, there is a slight reduction, but it is not as significant as your functional residual capacity. Tidal volume increases, inspirated reserve volume is mostly unchanged, and vital capacity is also almost unchanged. Now, this is a simple explanation of with the spirometry explaining the lung volume changes. If you see the total lung capacity is reduced by almost 5%, the vital capacity is unchanged. The tidal volume is increasing by almost 40, and the functional residual capacity decreases by 20. So if you can remember the percentage, then well and good. If not, at least remember the parameters which are increasing and reducing. Going on to the next question. This is once again back to the renal system. Where is the majority of bicarbonate reabsorbed in the nephron? Is it the proximal tubule? Is it the loop of Henle? Is it the distal tubule? Is it the collecting duct, or is it the renal pelvis? Nephron, structure of nephrons is the ions and the substances that are reabsorbed and excreted. Again, a time-tested question in exam. And now it is about the bicarbonates. The answer is proximal tubule. And a key tip to remember here is the proximal tubule is responsible for approximately 85 to 90% of absorption of most of the ions. So many a times you need to understand that if it's about absorption, take the proximal tubule, even if you don't know the right answer. The loop of Henle, the main role is in concentrating the urine, and there is no maximum absorption of bicarbonate that is seen there. What does the distal tubule do? In the distal tubule, there is fine tuning of the acid-base balance. And collecting duct, again, it regulates the acid secretion, but it's very, very less minimal compared to proximal tubule. The renal pelvis is not involved in the transport process or ions. Now, this is an image which you can remember for your exam. You have the structure of the nephron. You have the various parts marked. If you observe carefully, the proximal convoluted tubule is the one that is responsible for your glucose, amino acids, ions, and most of the substances. If you look at the loop of Henle, it's basically for urea and water. And going on more distally, we do have the ions, but it is less compared to the function of the proximal convoluted tubule. We have one more question related to the renal system. Which of the following substances is excreted unchanged in the urine? So the options we have here are, is it glucose, is it creatinine, is it urea, is it inulin, or is it amino acids? The right answer for this is inulin. Now, inulin is a substance that is freely filtered by the glomerulus. It is neither reabsorbed nor secreted. So what is the importance of this inulin? This inulin is used as a marker for measuring the glomerular filtration rate. Glucose important, so it will be reabsorbed completely if the a woman is got if she's a non-diabetic and she has other normal parameters, then glucose will be completely reabsorbed. Creatinine is partially secreted and you cannot use it as a marker for your GFR estimation. Same with urea. And amino acids, we know they are important for the body and it's completely reabsorbed in the proximal tubule in normal conditions. So this is something about the acid-base balance. But if you observe carefully, the question asks, what is the major buffer in the urine which maintains the acid-base balance? So is it your ammonium ions? Is it your bicarbonate ions? Is it phosphate? Is it uric acid or is it sulfates? So this is another important thing, understanding the buffers, especially of the urine. The right answer is your ammonium ions, and this plays as a primary urinary buffer. So what will this do? This is going to trap your hydrogen ions. So there is excretion of the acid. So ammonia is secreted in the tubular cells, and this ammonia, that is NH3, will combine with your hydrogen ions in the tubular lumen to form your ammonia. Bicarbonate is generally a substance or an ion that is reabsorbed, so it is not acting as a major buffer. Phosphate will play as a secondary role in buffer, but not as good as compared to ammonia. Uric acid, again, it is not having a role in buffering, and sulfates, it is having a very, very minimal role. So given all the options, we go with the option of ammonia. So understanding a bit about the acid-base balance and the buffers. The buffer system can be in the blood buffer, you have retention or excretion of hydrogen ions. The respiratory system, where you have your bicarbonate ions playing a vital role, and coming to your renal system. In renal system, what happens? There is either excretion or there is retention of these ions like H plus ions, your bicarbonate ions, sodium chloride, etc. So kidney acting as a buffer, and what is the role of the renal system in maintaining your acid-base balance? We know in proximal tubules, again, there's a lot of ion exchange, and this ammonia will get combined with the H plus ions, and that will lead to ammonium, which will be excreted. So the hydrogen ions are being trapped there. So your acidosis is being prevented. If you see in the entire path of the nephron, there is reabsorption and secretion of the ions. Finally, what happens when the concentrated urine reaches the collecting duct after all the absorption and excretion is done? Still, the urine can have secretion of H plus ions. So the urine will pass out the H plus ions, and the kidney will act as a buffering system in maintaining the acid-base balance. So going on to the next question. At what gestational age does the plasma volume peak during a normal pregnancy? So this is with regards to the hematological changes in pregnancy. The options that we have are, is it 12 weeks? Is it 20 weeks? Is it 28 weeks? Is it 34 weeks? Or is it 40 weeks? Now, the plasma volume, as we know, the right answer is an option D, that is the peaking is somewhere around 34 weeks. Okay, the level increases almost 40 to 50% compared to the pre-pregnancy. The plasma volume starts increasing by the first trimester, that is by around 12 weeks, but it is not reaching its peak. By 20 weeks, if you see, there is a significant increase in the plasma volume levels, but it still has time for further expansion, where we see the maximum expansion by around 32 to 34 weeks. After 34 weeks, there is no further increase of the plasma volume, and hence the physiological pregnancy, the physiological anemia of pregnancy is maximum experienced by a woman at around 32 to 34 weeks. These are some important physiological changes, the percentages that you have to keep in mind. If you look at the hematological changes, there's an increase in the total blood volume, primarily attributed by the increase in plasma volume as compared to the red blood cells, and that explains your physiological anemia of pregnancy. Coming to your cardiovascular system, you have your cardiac output, which increases by 40 to 50%. The stroke volume increases by 30%, heart rate by 15 to 25%, and intravascular volume by almost 45%. The oxygen consumption also significantly increases by almost 30 to 40%. This is a reduction expected to be seen in your systemic vascular resistance and in your diastolic blood pressure. Coming to another important question, the question here says, what is the Haldane effect in relation to oxygen and carbon dioxide transport? And we have various options given. So Haldane effect, Bohr effect, very, very important ones and very commonly seen in the exam too. So is it an increased oxygen delivery to the tissue in an acidic environment, or is it a decreased oxygen binding to hemoglobin at low pH, or is it increased carbon dioxide transport in deoxygenated blood, or is it decreased carbon dioxide binding to hemoglobin in oxygenated blood, or is it enhanced oxygen binding to hemoglobin in high pH environments? So let's try to understand the Haldane effect. Now, what do you mean by Haldane effect? It is nothing but an increased capacity of the deoxygenated hemoglobin to bind and transport carbon dioxide. So it will facilitate the removal from the tissues. So we have two effects. One is called as the Bohr effect and one is called as the Haldane effect. Let us try to understand what is the difference between both. So the Bohr effect is seen in the peripheries, and in the lungs, whatever changes we see is your Haldane effect. So what is happening in the lungs? There is more amount of oxygen, so there's an increase in the partial pressure of oxygen. Because of this increase in the partial pressure of oxygen, the less carbon dioxide is binding to hemoglobin. So this deoxygenated blood which reaches the lung will get released of the carbon dioxide, and carbon dioxide gets exhaled. This is the change we see in Haldane effect, which is seen in the lung. But the opposite of that is seen in the peripheries, which is we explain by Bohr effect. So Bohr effect is seen in the peripheries. So in the peripheries, what we expect, we want more oxygen to be given to the tissues and we want the carbon dioxide to be reabsorbed. So in an increased acidic environment, that is whenever there's more amount of the partial pressure of carbon dioxide, oxygen is going to bind less to hemoglobin, or in other words, more oxygen is given to the tissues and the carbon dioxide comes to the hemoglobin, and this deoxygenated blood goes to the from the lungs, it reaches up to the lungs, and in the lungs, when the oxygen is more, there is a release of this carbon dioxide, which is nothing but our Haldane effect. So going back to the options we had, the right option is answer C, which is Haldane effect. Option A, which says there's an increased oxygen delivery to tissues in acidic environment, is nothing but the Bohr effect. Decreased oxygen binding to hemoglobin at low pH, it is again a part of Bohr effect and it's not related to carbon dioxide. Decreased carbon dioxide binding to hemoglobin in oxygenated blood. While oxygenated hemoglobin binds less to carbon dioxide, but this is not the primary explanation of the Haldane effect. So going on to the next question, what is the functional unit of the kidney? So questions like these are really high scoring questions. You have direct answers and this is a straightforward question. Let's look at the options. We have the option of glomerulus, we have the option of nephron, loop of Henle, collecting duct and Bowman's capsule. So when we look at the options, all are parts of a nephron and the nephron is the functional unit of kidney. So this is the functional unit of kidney, it's the nephron, and the parts of the nephron, you have the afferent and the efferent arteriole, which is going to start giving in the capillaries where the primary filtration takes place. We have the Bowman's capsule. Following that, you have your proximal convoluted tubule, the loop of Henle, the descending and the ascending limbs, followed by the distal convoluted tubule, and finally you have the collecting ducts. So this is the structure of nephron, which is the functional unit of kidney. Now, what is the normal acid-base disturbance that is observed during pregnancy? because of the physiological changes. Do we expect the pregnant woman to have respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis, or is it mixed conditions? So the normal change in pregnancy is respiratory alkalosis. Now, why is it so? This is because of the increased minute ventilation, which is driven by the hormone progesterone. So this is going to stimulate your respiratory centers. Because of this, what happens? There's a slight reduction in the partial pressure of carbon dioxide and a compensated decrease in bicarbonate, leading to respiratory alkalosis. A respiratory acidosis is usually seen whenever the woman is hypoventilating. Metabolic acidosis is very commonly seen in diabetes, especially diabetic ketoacidosis. Metabolic alkalosis is seen when the woman is vomiting a lot, and mixed is usually very pathological and it is not a feature of a normal pregnancy. So normal pregnancy, it is respiratory alkalosis. So what happens in normal pregnancy? Some key points to remember. First thing, the pH is slightly decreased. The partial pressure of carbon dioxide is again decreased. Bicarbonate, because of this changes in the respiratory, there's a compensation of the bicarbonate reduction also. So significance is that all this are going to improve the carbon dioxide removal. So there is more amount of oxygen that goes into the fetus. So normal physiology is respiratory alkalosis. Going on to yet another important concept about the ECG. So ECG waveform, what does a normal waveform look like and what does it represent? And electrolyte imbalances and the ECG changes are a very, very important topic not to be forgotten for your exam. The question that we have here is a direct question which is asking us, what does the T wave in an ECG represent? Is it an atrial depolarization, a ventricular depolarization, a ventricular repolarization, an atrial repolarization, or is it representing a ventricular contraction? So the right answer here is ventricular repolarization, which is nothing but the recovery phase of the ventricles. Atrial depolarization is your P wave. Ventricular depolarization is the QRS complex. Atrial repolarization is usually not visible in an ECG because it is obscured by the QRS complex. And your ventricular contraction is basically your ST segment and not the T wave. So this is a representation of the electrical activity and the associated wave pattern. Coming to the next question, the question here is testing on the average half-life of RBC in circulation. So 30 days, 60 days, 120 days, 180 days or 240 days. The right answer is the average lifespan of a red blood cell is around 120 days. After 120 days, what happens to this RBC? They are removed by the spleen. 30 and 60 are very, very short for RBC to seen in pathological conditions. So some quick bite tips on the lifespans. RBC is 120, neutrophil is very short-lived, it's around 7 hours, and platelet is safe somewhere around 10 days. The lifespan of the WBCs is not constant. Neutrophils is somewhere around 2 to 5 days maximum. Eosinophils is 7 to 12 days. Basophils is 12 to 15 days. The monocytes is 2 to 5 days. And lymphocytes again very short-lived. So if you see, neutrophils is the first cell of the WBC that comes in response to any kind of infection and inflammation. And that's why it is something that you have to remember. But one point is, you might not expect a question on WBC because they do not have a constant lifespan. It depends on the pathological condition that the woman has got. However, for RBC and platelets, it is 120 days for RBC and around 10 days for platelets. We have one more question here. We have a 28-year-old woman who presents for her 20-week anomaly scan. The sonographer observes a well-functioning placenta with normal Doppler studies. Which of the following is the primary site of maternal-fetal exchange in the placenta? So the question, though they have given a long scenario, the basic question that is asked here is, where does the exchange, the maternal-fetal exchange take place? Is it at the umbilical cord? Is it the syncytial trophoblast? Is it the cytotrophoblast? Is it the intervillous space or is it the spiral arteries? So we need to understand the structure of the placenta. The right answer here is the intervillous space. Now, intervillous space is a place where basically the maternal bloods are present, and this is the place where the maternal blood comes in contact with the chorionic villi. Chorionic villi is nothing but it is the fetal portion of the placenta, and because in this interface there is a lot of exchange of the gases and the waste product. This is exactly the basic function of the placenta of exchange where it is going to take place. Umbilical cord is basically carrying the blood and the waste products between the placenta and the fetus. And coming to syncytial trophoblast is nothing but the outer layer of the placental villi. The main function here is to secrete hormones such as HCG. Coming to cytotrophoblast are nothing but the inner trophoblastic layer. They provide the support and differentiation for the syncytial trophoblast. Coming to spiral arteries are nothing but the maternal arteries, and this importance of spiral arteries is they get invaded by the trophoblast, which leads to dilatation of the spiral arteries, which is very, very essential for a normal pregnancy. When there is no trophoblastic invasion of the spiral arteries, that is when you come across conditions like fetal growth restrictions, and it is the basic pathophysiology we observe in hypertensive disorders of pregnancy. So this is nothing but a picture of the placenta. You have the maternal side and you have the fetal side. Now what happens in the maternal side? You have the intervillous space. You have the maternal arteries which come dilate, and the blood is in the intervillous space where maximum exchange is going to take place. And from the intervillous space, if you see the fetal parts is starting, you have the chorionic villi, the primary, secondary and the tertiary villi is there. And finally, they go on to make your umbilical cord, which is the final connection between the placenta and the fetus. So these are some very important questions on the module physiology. I hope this video will definitely help you prepare a bit better and also highlight some important points on this module of physiology. So all of us here in StudyMEDIC are praying for your success, and we're always there for you. And our YouTube videos has received more than 100K followers, and it's also contributed to all their success stories. I hope this video serves as the same for all of you all, and all the best from Team StudyMEDIC.